my pleasure and privilege to welcome you today here to listen to our keynote speaker. He is a Charrington Endowed Chair and Regents Professor of Pathology. He's also a Professor of Life Sciences and Bioengineering at the Nelson Mandela African Institute of Science and Technology and Infectious Diseases. He's also the director and founder of the Paul Allen School for Global Animal Health at Washington State University. He was elected to the National Academy of Science in 2006, and he's currently a member of the Board of Global Health in the Institute of Medicine. He has lots of titles, affiliations, awards, way too many to mention today. But please visit his website. It's got all that information there. It's very up to date, I promise. But one of the things that he has dear to his heart is that he's trained as a veterinarian and a pathologist. And I can see some of the pathologists in here in this room. So whenever I talk to him, that's his original passion. He has been a very strong advocate in research, and his research focuses on the interface of animal and human public health. And he has had funding from NIH, Bill and Melinda Gates Foundation, NSF, and he has published over 200 articles in peer-reviewed journals. So he is an excellent speaker to be here with us today. I met him for the first time in 2010 when, out of the blue, I emailed him because I had a symposium here for veterinary students that are interested in research, and he graciously accepted an invitation from a stranger to come and talk to the students about One Health. And I am doubly privileged because he answered my call again, and he's here today to talk to us. And let me tell you, you are in for a treat, okay? So without any further ado, I would like to introduce you Dr. Guy Palmer.
It's more advanced billing than you really want. Expectations can... I think I can. Yep, got it. Well, thank you, Susan. It's who would turn down an opportunity to come and be with you? I don't think anyone would do that. But it's a pleasure for me to be here, and I'm really excited by the program that was put together. And when I was making travel plans, I was looking at the full symposium, and I just thought this is a great opportunity. So I'm not leaving until the end of the day Saturday because I wanted to make sure I got all of the expertise. It's something I'm really looking forward to. I'm going to come back and talk about Superman and Spider-Man after a bit. So you'll have to wait till they reappear. But I really want to talk about within the philosophy of One Health, a little bit focused on the topic of global health. And this is a definition that was actually constructed by Jeff Copeland, the former director of CDC, now at Emory, head of global health there, and the consortiums of universities in global health. But I really want to highlight just about 3 things in here, and then expand a little bit on them as we talk about the lens from which we can see health from a different perspective, a much more multidisciplinary perspective. And the first is that this does involve a very strong social justice mission, which is the equity in health for all people. So it has social justice as a very implicit part of it. But it also has part of it the importance of transnational health issues, determinants, and solutions. And I think that's very important, especially when we deal with national governments who the only thing the population can agree on is they don't want foreign aid. They don't want any other programs cut, but they would like to cut foreign aid. But I think when we actually look at what we do in global health, the way we learn transnationally, we learn from things that work in other countries, in other more resource-limited settings that actually have great import to our health systems. And I'll try to bring out one of those later in my talk. And the other is that this, by its definition, is a One Health approach. It involves all of the health sciences and really multiple additional disciplines. What I want to kind of talk about as the overall message to this, and I want to be very clear, is that we want to look at problems in health not from a disciplinary perspective. We may apply our expertise in a disciplinary manner. We're obviously trained to do very specific things. We partner with other people with specific expertise. But we need to change somewhat the way we look at problems so that we're looking at them as educated world citizens rather than from a narrow disciplinary focus. So that will be my idea, and I'll try not to have a mixed message like this one. I didn't know, thank goodness it's not from the Liverpool Tramway Authority. I'd be embarrassed about that. So I'm going to talk about three examples, what we know and kind of what our challenges are as we try to actually deal with major health problems. And the first of those is one that's very important to me. It actually got me started in veterinary medicine in the first place, which is rabies. And rabies is still responsible for 50,000 human deaths every year, principally in children, as you can see from this young man who's been bitten on the face. And as most of you in this room would know, rabies is much more transmissible when someone is bitten on the head or neck, due to it being highly innervated and obviously close to the central nervous system. Children are much more at risk. One, just because of their size, they're much more likely to be bitten on the head or neck, but also because of predator-prey relationships. Almost all of the human rabies is in fact due to dog bites. So the predator-prey relationship is quite important in the transmission. So this is another indication. This is from close and neglected tropical diseases, looking at the number of human deaths per year. And so we see this rabies as a continual annual problem. Now I want to be very careful when I talk about a slide like this, because never want to get into this thing of this disease is more important than that one because it kills more people. Those are ridiculous arguments to get in, and that's not the purpose of this. I think the purpose of the challenge of this is we don't have to focus just on emerging diseases. This is a disease we've had with us for millennia, but it's a disease for which we have control. So I want to go to the interface of what control we have. But now if we look at this from a broader multidisciplinary lens, what do we need to do to take this 50,000 deaths down to essentially zero? So a lot of this work is based on a series of studies that we do as part of what's called the Serengeti Health Initiative. A lot of the work I'm going to talk to you was started by Sarah Cleveland at Glasgow, who did a lot of the real rigorous epidemiology work that we continue today in our vaccination campaigns. So this is in northern Tanzania, and there's two regions there. In the blue, you can see the Serengeti district. This is around Lake Victoria. It's very densely populated with villages. And then if you look to the east of the park, you're now into pastoralist area. These are mainly Maasai. And each of these dots then show you where we had village outbreaks of rabies in the last decade. So this is the data, biweekly cases of rabies in the two districts, in Ngorongoro district. They're in red in the Serengeti district, in blue, and you can see that it extended quite a long time. These outbreaks are actually fairly predictable when vaccination rates drop, and I'll give you a little bit of data for that. So the first thing that to actually look at is to begin to adapt a different framework in terms of what our strategy is going to be. And I want to emphasize the importance for good epidemiologic science as a backbone for what looks like just a very humanitarian approach. And that is, obviously here in the U.S., our approach is where we really deal with endemic wildlife rabies. We try to vaccinate 100% of the dogs. We do that through a very talented and widely dispersed veterinary workforce. We try to regulate it through dog licensing and other permits. And we probably hit some reasonably high percentage of vaccination, although the data on it is really not very good. What we do know is we don't see much human rabies due to dog bites. So to actually know what percentage of the population you're going to have to vaccinate, there had to be some fundamental epidemiology work done. And first, to dispense with the idea that, from the cartoons, that one rabid dog bites everything in sight and transmits to a ton of other dogs, because that's actually not true. So you can see in that first graph there, that's kind of the key. It shows you the dogs bitten per rabid dog there on the x-axis. And there you can see on the y-axis that actually most dogs transmit only to, it's a better one. It's a little bit better. Yeah, you can see there that most dogs transmit to a mean in a population basis of somewhere between 0 and 1 dogs, and it drops off fairly quickly. They don't bite too many other dogs and don't transmit to too many other dogs. So that allows us to determine the R sub naught, and I think in this room probably everyone knows what this is, but in the event there's someone who doesn't, it's how many during an infectious phase to how many other individuals a given individual infection will be transmitted. So if I'm infected with the common cold, to how many other people will I transmit during my infectious period? So if we look at something that's highly transmissible, like measles is a good example. Depending on the spatial structure of the population, it's probably between 12 and 18. If we look at rabies, it's very, very different. It's very low. And this is a variety of different studies. It's not much different if you look in South Asia, West Africa, East Africa. It's about 1.2. And that's important because as a population basis, if I'm infected with something and I cannot transmit while I'm in my infectious phase to at least one other individual, the outbreak by definition drops down to 0 and is eradicated on its own. So we're at 1.2. So we're not very far from where we can actually control these diseases. So this kind of graphically shows the same thing. If we think of that little black dot as just a rabid dog, and it's going to go out and transmit on average now to one additional dog, indicated by the other black dot, and it goes on just a little bit above 1 on a population basis. So obviously we vaccinate all 3 of those dogs, we're good to go. That's not rocket science. But you can imagine if you now vaccinate just one of those dogs, you now reduce the chances of stochastic probability that in fact when that dog bites another dog, that dog has already been vaccinated, and therefore it now drops to the transmission drops below 1. If we were to vaccinate 2 of those dogs, we'd really be in good shape. Now it gets into an odds game pretty quickly, and if you look at what the data actually looks like when you do that, it looks like this. The probability of an outbreak versus the population level from vaccination, and as I said, we've all figured out if you vaccinate 100% of the dogs, you're good to go. But you can see in terms of a big outbreak, 20 or more cases, somewhere around 50% it becomes asymptotic, meaning you don't have to vaccinate that high a percentage of the population in order to control the disease. So somewhere between 40 and 70% you begin to get control. So can you actually do that? That's the second part. In a low resource environment. This is a village. We do 2 kinds of vaccinations. This is a village central point where it's communicated to the community basically through word of mouth and community leaders that there's going to be a vaccination clinic. People come on their own accord. They come all day, and we'll do somewhere between 300 to 500 dogs. So you can see there's the common breed, which I call the Tanzanian tan dog. It's a very dominant breed there. And so it's generally children bring their dogs, and what we found actually is quite interesting. We get a lot of information from them in terms of their demographics. And we kind of realize now we're sitting actually on this also treasure trove of data about children, which we just were interested in them bringing their dogs initially. But when we changed our lens a little bit, we began to saw we also had access to children. So the other thing, I don't know if you can see this. This is my pet research project. I look at how names change over time. So this is the name of the dog here. So we get the name of the child. This is vaccination history, age of the dog. So you can see real popular names. Simba is very popular. Everyone knows Simba from Lion King. Chuli is pretty common. That's a leopard. But the ones that interest me are Osama is common. There's a couple of Osamas, and Saddam is very common. So these kids really like tough guy names for their dogs. I have no idea where they get this information, but they have identified these as tough guys. So this data, this is from 2011. So when we go back, I'm trying to follow up now what's happening. And occasionally an Obama shows up, but there's not very many Obamas. But now I'm kind of curious with time, is Obama going to come up, go down? What's happened with Saddam, Osama, and Obama? They're all in this together as far as the dog naming is concerned. Okay, so can we actually get access to the dogs? That's the first question. Yeah, and you actually can. People are very well aware of rabies because of the outbreaks. There is some concern that if you control it over a long period of time, do people still remain sensitized to the importance of rabies? We haven't seen a drop-off in terms of areas where we've controlled it now for 10 years. So you can see that people come in all kind of ingenious ways, bringing their dogs. And this is one of my favorites from a clinic last year. There's 4 dogs in here. He pedals up, and you can imagine that it's not really a smooth bike path or anything that he comes up on, but the dogs are quite happy. And the great thing is, you just vaccinate them right in the bucket, and then the guy rides off again. So it's a very efficient, way more efficient than what we're doing in our country. So it's great, but does it work? And it does. It works quite remarkably, showing, again, that the predictions from the epidemiologic data, in fact, can be translated into practice. So we've got the monthly incidence of cases, and then we've got a vaccinated zone in blue, and these indicate the vaccinations. And you can see even after 2 vaccinations campaigns, this really drops off dramatically in terms of the incidence of rabies. It controls it really very, very dramatically. And not only does it control rabies, it actually controls animal dog bites as well. And as you can see from that first picture with that child, the bite itself is quite traumatic, and you can imagine you're in an area without access to emergency medical care, without access to any kind of surgery that would repair that. There are other things that cause infections other than rabies from dog bites. So in fact, just reducing the dog bites, again, has a fairly broad public health significance. So the goal now is, how do you take this into something that is sustainable? Yes, it works. You can do it. The money basically to do these campaigns comes externally, comes from the Gates Foundation, comes from our initiatives that we do with the Lincoln Park Zoo to control rabies. How can you actually make this sustainable? Well, the first is to show that in fact you can control it. And this is an article by Sarah Cleveland in Close and Neglected Tropical Diseases, in which she argues very strongly that canine rabies can be eliminated, which would eliminate human rabies as a public health problem in sub-Saharan Africa. Unlike North America, there is no evidence that there are endemic wildlife reservoirs for rabies. It's really a dog problem. So it provides a pathway of where you could control this disease. The big problems we're running into are simply cost. Vaccination of these dogs, it costs us between $3 and $5 to vaccinate a dog. And the population can't pay for it at this point. These children don't have that kind of money. The Ministry of Health, they've actually done really a detailed economic analysis that shows it's far cheaper to prevent disease than to implement post-exposure prophylaxis, which is inconsistently available, and the likelihood that a child will receive post-exposure prophylaxis directly correlates with distance from medical care. So there's good evidence, but in fact you have a Ministry of Health that has a lot of other problems as well. They have an endemic malaria in much of Tanzania. They have a problem with HIV/AIDS, tuberculosis. This is not their only problem. So how do we now begin to look at how we can make this more sustainable? So there's 2 ways, and the hope is that, in fact, Tanzania, like many African countries, is getting wealthier, and it's getting wealthier fairly fast. If you look at the GDP growth compared to Asian countries, in fact, the tremendous amount of growth that is going on in Africa is really fantastic, and it's not all mineral wealth. They now have communications infrastructure, so in fact it's becoming a wealthier area. They will be able to, at some point, to implement and sustain this themselves. So if we can actually just move that target a little bit closer by dropping the costs, we'll then be able to speed the goal of eliminating human rabies. So there's 2 approaches, technological and community action. This is the technological one. This is the stupidest use of technology ever. This, apparently, the beer changes color. The beer label changes color when it's cold, which I like beer, but I've never had any trouble telling if a beer was cold enough. I actually just use my hand, and if it's cold in my hand, amazingly, it's cold when you drink it. The same technology, though, actually does have a use, which is in a cumulative temperature vaccine vial monitor, which is what this is. So it basically allows you, the difference in this vaccine vial monitor compared to the beer label is, once the label changes color because the vaccine has become too warm and therefore is no longer effective, it won't change back. Okay, you can't stick it back in the fridge. And amazingly, something so simple as that was a major problem, especially in the polio eradication campaign that have gone on. People have the cold vaccine, it sits out on a hot tarmac for a couple hours, but the workers, when they pick it up, they know it's supposed to be refrigerated, so they stick it back into the refrigerator. This actually takes care of that problem. But there's a better solution, and this really argues for the importance of basic discovery research. This is silk polymers. This is some very recent work that's been done at Tufts. And it's one of these serendipitous discoveries. It's from some biochemist who's really interested in silk proteins. That's what fascinates them. Not vaccines, not Africa, none of that. They're actually interested in silk proteins. But what they found is you can actually make these lattices of silk proteins that provide heat stability for both vaccines and, I'm going to show you later, antibiotics. So this is a series of data from their paper, which was recently published in PNAS, but I'm just going to show you one example, which is measles virus vaccine. So if you take measles vaccine, and obviously you stick it at 4 degrees C, it doesn't matter whether it's just the raw vaccine with the black squares, or it's in one of these silk lattices, it's obviously fine. If you have a refrigerator and a good power system, you don't need this. But let's say you have it now at 37 degrees. Now you look at the storage time. This is the residual potency in the vaccine, and you can see what happens to a standard vaccine. By about 12 weeks, it's basically come down to be worthless. Whereas if you put it in the lattices, fully polymerized or partially polymerized, you can actually protect it at 37 degrees. So this really has, great import for the kind of things that we're doing, because vaccine the cost of the cold transport is one of our major costs. If we can now store this vaccine at that kind of temperature, it not only allows us to get rid of the cold chain, it also allows us to store it at the community level. And now it now engage the second part of this, which is a community-led program. The second part of our major cost is transport, bringing people in to vaccinate the dogs. Well, community leaders it doesn't take a rocket scientist to vaccinate a dog. Okay, it can be done. People can be taught to do it. What we have always assumed, though, is once we put the needle in, that is a vaccinated and protected animal. And that's the data we have, epidemiologic data, would support that under the conditions we've done it so far. Now, can you turn this over to a community with a heat-stable vaccine and make the same assumption? So that's an ongoing study that's been proposed to the Wellcome Trust in collaboration with the University of Glasgow and Chatham House in London to kind of look at, can you now put this into the community in a way that would drop the costs? So we've got great data that shows it works, but the challenges we have to look at are now basically economic. How can we drive the cost down so that we make this a sustainable program? So the second example that I want to talk about is one well known, which is the demand how you feed a hungry world, especially with the increase in protein consumption, which I'll talk about in the third part, is the need for protein consumption as a part of not only health, but also of diplomacy and security. But the protein consumption that's increasing is mostly in low and middle income countries. Very little of that's going to occur in the US. And that has some real ramifications for how people are producing animals. And obviously this has been a hot topic for a long time in the US, is the feeding of antibiotics, essentially as growth promotants for livestock. And there's been great work done in Denmark to show they're probably the leaders in this. Under great conditions of biosecurity, you do not need antibiotics, you can remove them, and there's no one could possibly argue with that. The problem is most of the world doesn't actually look like Denmark. It looks quite different from Denmark. And what we see when we look at the rest of the world, which is where over 90% of the antibiotics are used, we see a very different situation. So this is data from Nigeria. These are commonly reported antibiotics used in poultry production. And poultry production is not what you kind of think of in typical terms in Africa. Some of the areas, it's 5 to 10 chickens owned by one household. They don't put any money into them. One day they come out, all the chickens are dead. They just get some new chickens, and they're back in the chicken business. These are peri-urban areas. Now they've got thousands of chickens, and they do the same thing that people do with poultry production everywhere. They get birds of the same genotype, they get them of the same age match, and you set up great conditions for infectious disease to spread through. So they cover the lack of biosecurity with antibiotics. And so I pick on chloramphenicol because obviously chloramphenicol has no allowable use in any food-producing animal. Its use has been criminalized in most Western countries for over 30 years due to dosage-dependent and dosage-independent aplastic anemia in humans. So if you look in Nigeria, though, you see a very different situation. So it's not just they say they use them, they actually do use them. In fact, they use them on the day that they take the eggs. So you look at the chloramphenicol residue in eggs. This is by farm. 40% of these in this one farm, but even the lowest ones, 15% of the eggs have detectable chloramphenicol. If you actually look in the meat in the markets, just go in and buy meat, you again find chloramphenicol residues. So they're not only using them, they're obviously using them quite indiscriminately. So these are the veterinary drugs containing chloramphenicol in Ibadan, Nigeria. They're all mixtures of antibiotics, and the interesting thing is where they are purported to come from. Netherlands, the UK, and Sweden, which is really interesting when you look at that at first, because it doesn't take much investigation to realize that's not where they're coming from at all. Almost all of these antibiotics are being produced in Asia. They're being repackaged multiple times, often diluted multiple times. And then at the end, they put on a manufacturer in a country that kind of has this seal of good housekeeping approval. So the Swedes would never do anything wrong for you. The British, geez, what gentlemen. They would never do anything wrong. So that everyone essentially can be a pharmaceutical manufacturer if you have an Epson printer these days. And that's what happens in much of this world. The other big concern with antibiotic use is how they're stored. It's not only intentional misuse. This is in Waso, Tanzania. And these are tetracyclines. And so I go around, I like to see what they're selling. And when I was in there, I asked them if I could put some notations on their labels as to when I came and when I came back. So I came back about a year later, and the same bottle is still sitting there. So what happens to tetracycline over time? The same thing that you see with vaccines, essentially. So normal tetracyclines are a nice kind of yellow color. So if you keep them in the refrigerator, again, they work great. They don't lose any potency. But you can see the oxidation that happens at a little more than room temperature, temperature and light, oxidation within 4 weeks, and at 37 degrees C, which is not uncommon in much of the low and middle income tropical countries, you see almost complete oxidation. So even if you're intending to use good antibiotics, what you're using is antibiotics that are ineffective. All of this is obviously promoting resistance. And resistance anywhere essentially is resistance everywhere. If Ebola virus can go around the world, in theory, or SARS can go within 24 hours, antibiotic resistance does the same thing. And humans are great carriers of antibiotic resistance. Somebody picks up a little traveler's diarrhea while they're visiting a safari or something like that. They come back, they don't feel good. They check into the hospital, and now you've got antibiotic-resistant organisms in the hospital environment. With lateral gene transfer, it's very quickly spread from one side into the other. So this is the same idea using silk polymers, and you can see what happens, just active tetracycline. 60 degrees is maybe a little bit high. Let's take 37 degrees as an example. It loses its potency within 4 weeks. You've got 20% active tetracycline remaining, whereas you can actually protect that by using these silk polymers. So there are formulations that actually could change the use of antibiotics. And this is important in thinking how you would do this, because this is an example of how you could actually have global to local learning. Yes, here in the U.S., we have sustainable power supplies. We do have access to refrigerators. But even here, a shelf is still cheaper than a refrigerator. So if you had these kind of products driven by the need to make them work in low-resource countries, it actually can change the way that we do things for decreased healthcare costs.
Just clarify one point. Are the polymers in suspension, or are they around the bottles? Or I can't quite visualize.
It's actually like, probably the best way to describe it would be, it's kind of like a microemulsion, except it's probably more like a nanoemulsion. And the third part of this is that we're learning as we begin to look at things from a more One Health and bring the environment into it, is we tend to think of antibiotic resistance as something that happens in animals. It's something that happens in humans, and kind of forget what happens to the environment. Well, most metabolites of antibiotics are actually secreted in the urine, and a lot of them are active metabolites at that point. So what happens to those? What actually begins to change the environmental microbiome. And that's significant, and this is something we're studying as part of the National Science Foundation program in northern Tanzania, because we have so much close human-animal contact. This is in a Masai boma, and I'll show you the next picture how many animals are actually in there. But you can see the close contact between animals and humans. Obviously, the urine goes right into this environment, and Maasai do treat their animals with large numbers of antibiotics, not all of which are effective. And you can see what happens. So now you can imagine the environment you've set up in terms of actually having an environmental reservoir for antimicrobial resistance. So this is something that we've actually been kind of addressing, kind of like looking at this from a One Health perspective. This is a recent publication from the Institute of Medicine where we begin to look at that and taking the great examples of what's been done in Denmark and certainly saying that this is what high-income countries should do. They should substitute good biosecurity for using antibiotics as kind of a poor person's biosecurity. But realizing that alone will not solve the problem, nor will regulation. There has to be some kind of market-driven approach to get good antibiotics, effective antibiotics, into the hands of the users and actually show them that will give them the results they want. So I've kind of thought about that quite a bit, and again, trying to change the lens in which we look at things. And the best example I can think of is, and it's a good thing coming to Atlanta, it kind of reinforced this. I didn't do it just because I came to Atlanta, but looking at what happens with Coca-Cola. Even you get Coca-Cola anywhere in sub-Saharan Africa. Actually, Coca-Cola is the largest private employer in all of sub-Saharan Africa. But they actually maintain their quality product and their data flow all the way through their distribution channels. So even in the most remote place. The difference is that there's a quality control that the consumer can do. The end user can tell, actually, if that's Coca-Cola or something very, very much like Coca-Cola. We don't know that when we have a vaccine or we pick up a pharmaceutical. It's done on a different way. It's actually, the chain there is what's called a chain of confidence. You trust the individual who's giving it to you. And it's amazing when you think about your own interactions with healthcare providers, how often you do that. When you go to the pharmacist, you have no idea, actually, what they're giving you. You just take it on faith that they have a good relationship, this confidence chain that goes up to the person who supplies it to them and on up. And you can see it's not done by regulation. It's actually done by this chain of confidence, which is kind of more driven by marketing than it's driven by regulation. Because as we all know, FDA does not regulate all of those or does not inspect all of those products along that chain. And as we've seen in the last year, that chain can break down, and it's not picked up by regulation. It's picked up when there's a problem at the end user level. So how can we create these chains of confidence in low and middle income countries? Well, I think that's a real challenge, but it's to move away from buying antibiotics in this kind of environment and something like this. And this is some work that Christy Peacock is doing. Christy was the head of Farm Africa for a long time. And she's actually started this franchise of animal health. This is in Kenya. Animal health, what they call livestock service centers. And the idea is to actually create this chain of confidence so that, in fact, you know you're buying a reliable antibiotic from somebody. You get information on the proper storage of it, the proper dose. You get better results, and you begin to create this chain of confidence. I'm not sure this is the total answer. It's probably going to require a combination of regulation, but it's all going to have to require market forces. I think the market forces, in the absence of this, for production would just overwhelm any regulatory environments in most of the world for at least decades to come. Okay, I said I'd come back to Spider-Man and Superman. So these are, I would say, pretty healthy-looking 6- and 7-year-old boys, just as a guess. But actually, because of the demographic data, we know they're not 6 and 7. These boys are 13 and 14. So these are undersized children, part of something that's kind of known as stunting, which is highly prevalent in sub-Saharan Africa. 42% of the children are actually physically stunted. Physical stunting is obviously a great disadvantage for them in their lives, but the biggest disadvantage is physical stunting is usually accompanied by cognitive stunting. They're not able to fully develop their intellectual abilities. So now you take that and you look at this as a problem of a regional problem. Yes, it's a tragedy for this individual, for their family, but it becomes a problem for the country. This is where things now become issues such as recruitment of boy soldiers, easy incitement of ethnic violence, because you're dealing with people who aren't well educated, don't have full cognitive abilities. You end up with gender violence. And these are the kind of things that I think, if we're really to take a One Health approach, we need to actually step back and look at all of those perspectives. Drought leads to gender violence, because drought leads to migration. When migration occurs, the most vulnerable are always women. So I think when we look at One Health, we have to move beyond kind of our comfort zone of, yes, I know a lot about zoonoses, and I'm pretty comfortable with those. I'm pretty comfortable with rabies. And that may be the area where I can have my expertise, but I think the vision has to be stepped back and looked at how this fits into the broader context. So this stunting comes about by two things. First is malnutrition, especially protein malnutrition. So this is from worldmapper.org. So this is what the world looks like if, instead of Cartesian geography, you put it in terms of where you see protein malnutrition in the first 1,000 days of life. You can see it's mostly sub-Saharan Africa and South Asia. Some obviously occurs in other parts of the world. And this is where you see diarrhea, severe cases of diarrhea in the first 1,000 days. Obviously, diarrhea in children occurs in almost all of the world, but you can see the higher prevalence in sub-Saharan Africa and India. It's when you put those two things together that you see this now occurring from mother to child in an intergenerational span that you begin to see the problem. And this is where you get malabsorption syndromes. And it's malabsorption syndromes in those first 1,000 days that lead to this physical and cognitive stunting. So what's causing this? It's a multifactorial problem. There's a lot of human-to-human transmission, rotaviruses, typhoid salmonellas, and because in the areas we're working in Western Kenya, there's a real lack of latrines. So there's community-led efforts such as this. If you didn't know what an ODF village was, now you do. It's an open defecation-free village. And there's a real movement, just very simple things like that at a community-led level. There's been obviously a lot of work, and all of you would be familiar with improved water purification projects. And yet when they've looked at them, their success has been pretty spotty. And so the question is, why is that success been kind of so intermittent at best, not near as dramatic as we thought it would be? Well, part of it is, if you're going to drink purified water, clean water, you have to do it all the time. You can't do it 9 out of 10 times. That doesn't work. And I think that's one of the big problems we see. So this is an area, this is also in Western Kenya, this is what's called a well. We would call it a pond. But it's an area where they basically dig it out, collects during the rainy season, and you can see people down there with bicycles. They collect water that's used for household use. The animals walk right into this same region. And you all know what animals do when they walk into water. They leave something behind. So this is a really, really rich microbial environment. And it also just fits into their local economies. This is just kind of an example. This is kind of an ingenious way of looking at how they slaughter animals. This is also in Western Kenya, where they have adapted to no ability to refrigerate carcasses or meat. So every animal sits out there and they just graze they've already been sold to a middleman. He now holds on to the animals until every piece of that animal is allocated for, down to the hooves, the hide, everything. So then, early in the morning, because there's no refrigeration, once it's all spoken for, they go in. This is an approved slaughter slab. This is part of the government. And then people show up right away. They collect all parts of this animal. So somebody takes it and immediately goes off. It's unrefrigerated, so it has to be sold right away because it has to be cooked before long. And you can see the stack of hides there in the foreground. So every piece of this animal, even the hooves, go somewhere. So everything gets taken away. There's nothing left. By about 10 in the morning, there's nothing left at this place, except this. This is where all of that, the offal, the manure, everything else washes down into this holding stream. And now you can see, this obviously looks a little nasty. It's very green around it, you'll notice. But also you'll notice down below here, this is a stream, and the stream then runs into a village. So it's basically just a recontamination of the environment. So it's a huge environmental issue in terms of this. So you can see that trying just to handle this with a single fix, a single clean water source, is a real challenge, because you would have to make sure that it's continually used in all its aspects. So we're starting to look at stunting from a really broad perspective, and this is a study we're doing in collaboration with the CDC and the Kenya Medical Research Institute in Western Kenya. So just to kind of show you where this is, obviously you know where Kenya is, but it's kind of out here near Kisumu. CDC's largest headquarters outside of the U.S. Is in Kenya. It's been there since the mid-'70s. And so if we go from that little part of the Lake Victoria, it's in this region called Asimbo. And in Asimbo, what we basically do is we look at 1,600 households. And we look at them in really two major ways. We look at them every 2 weeks in terms of human health and animal health. All of these, more than 80% of the households have animals in close proximity to them that they own. So every 2 weeks we look at 4 syndromes: jaundice, fever, respiratory disease, and diarrhea. And I'll show you just an example of those questions in the humans. So there's specific questions such as, did you sleep under a mosquito net last night? Not do you have one, that's a very different question. Did you sleep under one last night? And you ask the same question for all of the children. I'll give you some examples of that. We ask questions about the animals, the health of the animals, additions, births, deaths, those kind of things. We also get an idea every 3 months. We go in and we get a complete look at the household assets. That is, we want to know the nutrition that's coming into the household. We want anthropomorphic measurements on the children. Are they growing normally? We haven't yet started the cognitive studies, but we're going for approval through KEMRI to actually do cognitive testing. And then we want to know how that nutrition is distributed within the family. Who actually makes that decision? And that becomes very important because of the role of pregnant women. Pregnant women who are undernourished already are much more likely to give birth to a stunted child. As we even get more sophisticated, and I'm sure many people here have really followed with interest the microbiome studies, especially the interesting study recently in Malawi about the microbiome and kwashiorkor, looking at that relation of the microbiome of the mother to the child in these conditions of nutrition. So we're looking at this in a pretty broad-based way. So each of these 1,600 households, if you look above the household, it has a number. So we have spatial maps on all of this stuff. We have, we know who the respondents are, who answers for the household. It's usually the woman of the household. It's usually, some of these are polygamous households, so it may be the senior wife. But if there are multiple households within a compound, we get data on each household, because obviously resources can be, when there's a senior wife and a junior wife, the resources aren't necessarily shared equally. This is our staff, which actually takes care of all this information. We do all this stuff on smartphones. We upload it at the end of the day into a server, and then we download it actually in Pullman the same day. This is our team. So we have a team of veterinarians, computer scientists, epidemiologists that kind of all work together on this program, and community interviewers, who are really the key to this. So this is what these households look like, a household compound. There's a lot of children, as you would imagine. The percentage of children under the age of 15 is very high in this area. It's usually it's a mixed area. They do have animals, but almost all of these have crops, large number of maize, ground nuts, variety of crops, which we want to measure both what they do with those crops. Do they sell them? Do they pay for additional crops? We want to know all of the nutrition flowing in and out of the house, as well as off-farm income. Again, most of these have animals. They have relatively few animals, but the animals, I was kind of embarrassed for this guy. I really was not taking a picture of his rear end. I was taking a picture of how close the connection between animals and humans is. It's just remarkable, the number of contacts every day that occur. So we generally go in, we talk then to, in this case, she's the head of the household. So we speak with her, she answers these questions, and they basically all get then uploaded into this information, this animal health survey or economic assessment. The economic assessment takes about an hour the first time that it's done. It takes less time after that. they don't have a tremendous number of assets, so it doesn't take a lot of time to see what the change in assets are once you've established the baseline. So we get household demographics, the number of children in the household, female children, male. We get all of the demographics of what's occurred in the household. We get then the population-based data for animals. We get the same thing for humans. And the goal is to bring these data streams together to try to look at this now in a holistic way, because I think simple one-time interventions are very unlikely to address this problem. So human health characteristics, just to give you an idea of the kind of questions. A question like, has someone in the household had diarrhea, ends up to be kind of a silly question. That doesn't give you a lot of information. What you really want to do is something of what's the impact of that case of diarrhea. So you can see it in a case of this, how many days of on-farm work have been missed due to illness. So we want to know if there's diarrhea, is it severe enough that someone didn't go to get water, they didn't do any work with the animals, they didn't do off-farm work, etc. So we actually want to look at the impacts of disease in terms of this. So why do they do that? You're starting to think, you talk to these people every 2 weeks, you ask them all these questions about their assets, why would they possibly do this? One, I think some of them enjoy a Mzungu coming by now and then. I think it amuses them. That's one explanation, but there's a better explanation, which is the CDC and KEMRI have long set up this agreement. So the region that we look at, these 1,600 households, are all within 5 kilometers, which is basically walking distance of a mission hospital. And this is the mission hospital. As being a part of this program, they get free medical care. So they can go there for any of their cases that they think are severe enough that they need to get care for. The nice thing about that is this has one of the best serum banks you could imagine. The compliance they get in terms of acute and convalescent serums is amazing, and they generally also get control serum from another member of the household. Their serum bank is probably unprecedented, I think, and it's just because of this process they've gone through. On the animal side, what we do is we provide them with information on sick animals, and we have a team that goes out. So if the community interviewers go by bicycle, but if there's animals that are sick, an animal has died, they actually contact somebody with an SMS message, they come by a motorcycle, and they can do a necropsy. These are trained animal health technicians. And we look for things like, is there evidence, first and foremost, is there evidence that this is a zoonosis? This is an area that's endemic for anthrax. So that's the number one thing we pay attention to. Number two is to give them some information. How likely is it this is something that's going to spread among their animals? That's something that causes them a great concern because a high percentage of their assets are tied up into their animals. Or in the case of this animal, it was malnutrition of the animal, and it's probably very little risk for it to be spread. So we do postmortems. Then they actually talk to the owner of the household to relay that information. So we're trying to build some capacity within the region. And then we have meetings then among the animal health technicians and our veterinarians there in order to strengthen the capacity of the animal health technicians to actually be sure they're giving good information. So while we're extracting data for our own purposes, we are trying to leave a better infrastructure for terms of dealing with diseases. So our goal in doing this study is to really look at this from a different lens, and that's to look not at individuals by the individuals, and that's either from an animal perspective or a human perspective, but actually begin to look at the whole family. To look at the family, the nutrition, how nutrition gets divided up within the family. Do pregnant mothers get additional food? How can that be influenced? How are those food decisions made? So there's a great deal of medical anthropology and sociology tied up into this to understand decisions for food allocation within the family. The overall goal, when we kind of look at this, when I think, how would you know if you're doing anything? And that's really hard to do. You can actually measure interventions through controlled studies. You can measure interventions during broad case control studies. But the long-term goal, one of the best determinants we can actually find is to look at the percentage of girls that are in primary school. And what this actually shows, this is from World Mapper, this shows you the proportion of girls who are not in primary school worldwide. And you can see where they sit. They sit in the least developed parts of the world. The percentage of girls that are actually in primary school is the best determinant of growth of an economy in a country. So that's kind of the metric that as we start with something as simple as rabies or as complex as antimicrobial resistance, the goal we're looking for at the end is actually something that is evidence that you're actually beginning to change the society. You're starting to see differences in education. You're starting to see differences in health. Because in the end, the goal is not just eradication of rabies. It's not just control of antimicrobial resistance. It's actually something like this picture. You want to see happy, healthy kids, cognitive abilities, the opportunity to attend school, and the opportunity to maximize their potential, their family's potential, the potential of their country, and the potential of their region. And I think we could all argue that not only benefits them, that benefits us as well. So that, I'd like to say thank you very much for your attention.
I think we have some time for questions. Anybody has any questions for Dr. Palmer? Okay.
In the rabies situation, why is there not a wildlife reservoir?
I don't know why there isn't. There just doesn't seem to be, and it doesn't seem to spread into them. It seems to be constrained in it's just maybe not endemic in them to start with. And it obviously doesn't spread from the dogs into the wildlife. In the hyena-dog interactions, the hyena usually wins. So the dog doesn't get many bites in. So it actually doesn't seem to go in. And when they've controlled, and the best data for that, it's a little tricky to say there's no wildlife reservoir. I mean, you have to have some caution with that. But the best evidence is probably from the Serengeti Health Initiative. And that is, when they were seeing rabies in the park, in wildlife, when they were seeing, you probably remember well, the distemper cases they were seeing in the big cats and stuff. When they actually controlled it in the dog population surrounding the park, which is actually the origin of the Serengeti Health Initiative, which came out of the Carnivore Disease Project, they actually eradicated it within the park. They didn't see the problem anymore.
Can you expand somewhat on the Institute of Medicine report as to particularly what some of the, like the public health people, the MDs and the veterinarians are confronting the issue of antibiotic resistance?
Well, yeah, it's good. It's a great question. I'm not sure we're confronting it very well at the moment, because I think the big concern has been when they've began to talk about antimicrobial use in animals, it's always been driven a little bit from the perspective of, you should not use antibiotics as growth promotants in animal agriculture. And I think that makes sense for wealthy countries. I think we've made kind of two mistakes in that way. One is we've not done a very good job, the Department of Agriculture here in the U.S. and other agencies, of providing livestock producers with alternatives. We know enough about the microbiome. We know there are other ways other than antibiotics to actually change the microbiome and improve animals. There's just not been much research done in that area. But I think the emphasis is always on, remove the antibiotics from livestock use in the U.S. like they've done in Denmark. And I think it makes sense. I think the big issue is that won't change the problem. The problem is actually, it's a global problem because of the use otherwise. And I think that just hasn't been recognized very much. People haven't wanted to look at that, how much that occurs. And I think is from very basic studies, what we've learned over the last 2 decades about lateral gene transfer among Enterobacteriaceae, combined with this indiscriminate use of antibiotics, I think we've now got a much better idea of what's occurring. And I think it needs to be pushed that way. The IOM report that came out last year, really put a lot of emphasis on regulation, and I think that's a great idea. I just not sure regulating Nigeria is the best approach to do things. It might work. I think recent experience in northern Nigeria would argue that's probably not a very successful approach. So I think it just requires some different ways of looking at it. There's not one solution. I think there can be market-driven solutions, because I think the end user still wants an effective antibiotic. I think that's true.
Just to continue on that question, the extent of use of antibiotics. I mean, you gave the example of the Nigerian poultry factory. I mean, having worked in Africa, knowing the rarity of antibiotics for humans, also how much is this, how widespread is the indiscriminate use of antibiotics?
Extremely widespread. The best study, so we're doing a study in Tanzania now looking at, just a very simple study. We just buy antibiotics and test whether they're still effective or not. A similar study in Kenya showed that 80% of the antibiotics were under strength, fraudulent, or completely mislabeled. They weren't even what they were supposed to be. So I think it's a huge problem, and growing. I don't think it's becoming less of a problem. It's becoming more of a problem because of the rise of these peri-urban production areas. So we do some work in, there's kind of a well-known slum in Nairobi called Kibera. It was recently, there's a nice article in The Economist about it a couple of weeks ago. We've never been CDC's headquarters are just right on the edge of this slum. So it's, you're kind of in this little corner of the United States, then you look over the fence and it looks really dramatically different. And when we had been working with the CDC people, we had never been very interested in Kibera because, well, there's not much livestock in there. There's some chickens and, rats that are there, and there's been some work done on zoonoses in rats there. But we began to actually think of it from a different viewpoint. And there's about one latrine for every 1,300 people in the slum. So, and it's somewhere between 300,000 and 700,000 people live in there. They don't even have a good idea how many people live. But we began to think, how much food flows into that slum every day to feed those people? And where does that food come from? And in the work we've done, actually, no one seems to be able to answer that question. I mean, it comes in, you can see it, you can go out and observe it, but where it's coming from, it's completely unregulated, of course. So what's the food coming into there? How's that distributed? And then, obviously, what's going out the other end? When you have that many people in one latrine for every 1,300, it's a real mess. So.
A somewhat related question. What's the typical diet of the 1,600 households that you're studying? And
yeah.
What's the primary source of protein?
The primary source of protein, it's one of the big problems is there's not a lot of source of protein. It's probably maize. Maize is the biggest part of their diet. It forms something called ugali, which is kind of a cornbread kind of type thing. But it's probably not very high protein maize, so I think protein is the big problem. Ugali is, I think, typical of what you see. It's very filling, but you'll be hungry again before too long. It doesn't have much protein in it. So the protein that does come, it tends, we're interested in how much, because almost every household has eggs, how many eggs they actually use for consumption and how they make those decisions. We don't have the full set of data yet to answer that question. But I think anecdotally, we're already surprised by how infrequently they use eggs as a protein source. They tend to value having chickens more than the eggs, so they tend to let them hatch and go that way. So it seems, to us at least, to be a very underutilized protein source.
Guy, I think you said that during your rabies vaccination program that the incidence of dog bite reduced. And I was just wondering, it didn't seem obvious to me why that would be. Can you enlighten me?
Yeah, I don't, it's a good question that I don't know the answer to. I don't know if what you're doing is you're actually just removing, aggressive dogs, rabid dogs, and then there's something that kind of goes through the animals in terms of when you have aggressive, rabid dogs in the population, you obviously begin to change the structure of the dogs so that they become more aggressive, they become more defensive. You know, I'm not sure. It's a good question that I don't have the answer. There's a graduate student there who's actually doing some more. What we don't know about the demographics of the dogs there is pretty shocking. So it all looks good. You know, I told you the good part. You get into the details of, like, how long does, you know, an average dog live there? And we'd say, not particularly long. That's not a very good answer, obviously, because it's very important to us because of the population immunity. Once we vaccinate a dog, we'd like them to live a long time. But we really don't know what happens to them. We have a huge problem in terms of marking dogs to actually know a dog's been vaccinated. We really rely on the kids bringing a certificate with them, which sounds pretty flimsy, except that most of those families have relatively few documents that they actually do tend to hang on to them with surprising frequency. But we need a better method. So we've actually been looking at, and microchips are way too expensive, but we've kind of looked at the idea of some kind of nanochip, you know, that just gives you a positive, negative signal. It's a binary chip, which people say you can do much cheaper. The innovation in this is actually coming in the shipping container industry. It doesn't have anything to do with health, because they like to track things really, really cheaply. So we're looking at some kind of nanochips. The other idea is could you have a nanochip that would actually, the signal would decay at some rate that would approximate the decay of protective immunity, which sounds a little sci-fi, but actually when you talk to people who do those kind of things, that doesn't sound like a big problem to them. They just don't understand why you'd want to know that. So it's a little bit talking across some silos there. But it's a pretty interesting question that we're working hard to get at, because we don't understand the demographics of the dogs very well. And it's certainly important to do so.
Okay, we have a reception. You should have your wine tickets, so beverage tickets with you. So let's follow this discussion and conversation to the reception, and thank you very much.
Thank you.